Thank you, Andrew, for your introduction, and thank you for inviting me to be a speaker here. The fact that there are a lot of repeat participants, repeat offenders, attests to the value of your course. I'm going to cover 2 lectures very quickly. This is the commercial break before the other surgery starts. First, on the image guidance in endoscopic sinus surgery. Well, I'm from Singapore. We always have a lot of water problems, even though we have a river running through us. That is the Tan Tock Seng Hospital where I work, a 1,000-bedded hospital, and I have about 8 ENT specialists working with me. This is going to be a level 1 kind of lecture because I think most ENT surgeons who do FESS do not have an image-guided system simply because it's just too expensive at the moment. I'm going to go through the basics. You have an idea of what it is, and next time when you have the money to buy one, you know what to do. Yeah? Image-guided system is like it's an enabling tool. It's like a heads-up display for a jet F-16 fighter, so you can hit the bad guys and leave the good guys alone. So don't hit the orbit, don't hit the brain. It has been argued that it may decrease mobility, it may enhance surgical results, and that is what I convinced the administrators in my hospital that I was going to do that with the machine, and we convinced them I got the machine and the money to buy it. Image-guided system was first developed for neurosurgical and spinal procedures, and it was first applied to FESS in the late 1980s. It allows us to have very good preoperative imaging data because we can see a spot in 3 planes on the CT scans, a coronal, axial, and a sagittal plane. And it gives us very precise intraoperative localization. For example, this picture, the probe is here where we think it is close to the nasolacrimal duct. Further back is the uncinate process, so you can see the nasolacrimal duct is here. The components, it consists of computer workstation, the display system. There are 2 types of tracking system being used today. One is electromagnetic system, and the other one is optical system. There are specific surgical instruments to be used. We will need data transfer hardware and software for the image-guided system. Here you can see a computer workstation and a visual display. Yeah? Tracking systems could be electromagnetic or optical. Yeah? The electromagnetic system is the VTI, now procured by GE, and the infrared, either light-emitting diodes from the instruments or reflective spheres from the instruments. The tracking systems include optical, where you would require a camera above the patient for tracking of the devices, or electromagnetic, where there's no camera involved. We need a data transfer hardware where the patient has a CT scan done. It can either go by a network into the computer workstation in the operating theatre or through magnetic optical discs. There are certain instruments have to be adapted for tracking, and these are aspirators, but it can be 0, 45, 90 degree, sinus forceps, and microdebriders. In this case, you see an instrument. This is the microdebrider, where there is a reflective sphere attached to it. Yeah? They must have software to allow us to use this hardware in one functional unit. How does it work? We need to know 2 technical terms. One is called operative field volume, within which the system works. And 2, the dynamic reference frame. There are points in space in which the tracking system will recognize. So the operative field volume for an optical system would be the area in which the infrared emission of the camera covers, yeah? Outside which the tracking is lost. Dynamic reference frames, there are 2. One is a fixed reference dynamic reference frame, where the computer fixes a point at the patient's head in order to have a relationship between the mobile and this fixed reference point. Yeah? The mobile reference points are the surgical instruments that we use on the patient. And again, these can be either an electromagnetic system or an optical system. So it works by tracking the relative positions of the dynamic reference frames, the fixed reference frame to the mobile reference frame within this operative field volume. Now, it works by calculating the instrument tip position. For example, the instrument tip is inside the nose, and the computer knows the geometry between the instrument tip and this dynamic reference frame. So it follows, as you move this dynamic reference frame, it tracks this dynamic reference frame, projects the tip onto the preoperative CT scan. So the system does not see the instrument tip because the instrument tip is actually inside the nose. Yeah? So before we start using the image guided system, we have to register it. We have to calibrate it to define points on a preoperative CT scan and correspond it to the points in the operative field volume. Yeah? And all subsequent localizations will then be calculated relative to your calibration. So how do we calibrate it? We can do it by electromagnetic means. The Instatrack method, we turn the probe into 4 quadrants, and after that it is registered. It's very fast, very simple. The other method, optical method, would be you have to calibrate the instrument to the camera preoperatively. So for registration, we need a fixed dynamic reference frame. There are different types of fixed dynamic reference frames which has evolved with the use of the image guidance systems. So Fudishos are the fixed dynamic reference frames. They can be bone-anchored, surface, or anatomic. There can be headsets containing Fudishos, and there can be surface registration without need to use Fudishos. Now, for bone-anchored Fudisho registration, initial ones used in Philips, this is where Fudisho screws. The screw is screwed into the patient's skull before the CT, and the CT is taken. This is the most accurate because nothing moves. But, well, if you're going for neurosurgery, it's okay to have a screw in your head. Yeah? But if you're going for FESS, then it's not very practical. Yeah? The other method is a surface registration where markers are pasted onto the patient's skin the night or the day before the operation. CT scan is done, and then the patient is then brought into theatre together with these Fudishos. Often there can be soft tissue mobilization, right, when the patient sleeps at night, and it's not a very practical method. And because of these constraints, image guided system didn't really take off very well in ENT or for FESS. One other system is where we set up the system, the patient is on the table, and we use anatomic points pointing to the tragus, the canthus, the nose, and the columella, and registering this to the computer just before the operation. This particular registration is fairly accurate because there are many points for you to take. One other system is the patient wearing a headset. The patient wears a headset for the CT scan, and then the headset, identical headset, is used for the patient when they're in the operating theatre. It makes use of the fact that the headset is placed on the patient's nasal bridge and on the ear canals, so that this headset is always in the same position when it's under the CT scan and when it's during the operation. Sometimes problems of inaccuracy can arise when the headsets are not put properly into the ear canal. So like in this case, where this can be reproduced in the operating theatre, but this cannot be because this is outside the ear canal. Besides using the anatomic points, BrainLab system uses a system where we run a laser over the face, and this measures the contours of the face and allows for registration. Yeah, so there are different types of registration methods. For the future, some software manipulation. I was in Cleveland Clinic where they were working on this particular software where you color the orbit. You can take out the pre-op CT scan, color it yellow with your mouse, and then project it on the computer. So when you are working in the nose, you will see that the orbit is colored yellow. Yeah? And this will move together with the operation. So the orbit will be safe. Very much like Star Wars as you're flying your fighter into the Death Star. Yeah? So the advantages of the image guided system is that it gives you a preoperative review, and you can have interactive surgical navigation. It helps for planning because we can see points in 3 orthogonal planes. For example, in this planning, you will see that this frontal sinus has 2 openings because it's got an intersinus cell, interfrontal sinus cell. So there's one opening on the lateral aspect and one opening on the medial aspect. The opening on the middle aspect, which is the opening of the intersinus frontal cell. So in an op, you would want to know that this configuration is there, and therefore open up the bridge between the two cells for drainage. In planning 2, we can use it to see a supraorbital ethmoid cell here, above the orbit, here, and here. Yeah? You can confirm to us an Onodi cell, which, as you have heard Professor Womar say, is an extension of the posterior ethmoid lateral, but more importantly, superior and over the sphenoid sinus. Yeah? And here it is in close relationship with the optic nerve. We can use it to identify the nasolacrimal duct, although it's not always necessary. Here, the pointer is put right just next to the nasolacrimal duct, and so we pull it further back. We can see that we are push it further forward. We can see that we are away from the nasolacrimal duct. As you know, in anatomic dissections, the duct curves this way, posteriorly in the nose on the lateral wall. So as you are taking the uncinate process here, is in danger of being cut. Yeah? In the sphenoid, well, you have seen how Professor Womar approaches the sphenoid by taking away the superior meatus. Some time ago, Bolger has described entering the sphenoid through a transethmoid route, and has described a method where you draw a quadrangle, the base of skull, the lamina papyracea, the superior turbinate, the attachment of the turbinate to the lateral wall, drop a diagonal, and enter into the lowermost triangle. So how low in the lowermost triangle? If you were to put this tracker here, it is still not low enough. As you can see, it is still, if you entered here, you will still enter the skull base on the sagittal view. Yeah? You have to take it at the lowest most angle of this triangle here, and we will just enter into the top of the frontal sinus. Yeah? So it must go low and medium. It also helps us to define the skull base. Yeah? As you can see, the pointer is here, and you can see it's at the skull base. Like in frontal sinus revision, if you look at this patient, if this were the middle turbinate, you might think that the frontal sinus is somewhere here. Yeah? But it's not, because the middle turbinate had been resected previously in surgery. So if you were to put a probe here, it's actually just at the tip of this cut edge of the middle turbinate, and it's very far away from the frontal sinus. As I move the probe further forward, further anteriorly, on the medial aspect is the skull base. Yeah? And as I move it more laterally, the frontal sinus opening is actually here. Yeah? And that this is the resected part of the middle turbinate. And this helps us to gain entrance into the frontal sinus more safely, more accurately. There are limitations to image-guided system. It is not in real time. Its accuracy is dependent on the CT scan, and the navigation accuracy needs constant monitoring. We are now doing slices of 1 millimeter, and therefore accuracy is at best at 1 millimeter. They are reconstructed from axial scans, although at the moment these reconstructions are fine. Yeah? Things may move as you do surgery, so it's important that we always verify with a verification point where we are as we are using the system, so that we don't trust the system completely, and then we might go through the skull base. Yeah? It's not in real time. For example, in this particular patient, the anterior wall of the sphenoid has been removed, yeah, for a repair, yeah, of the back of the sphenoid. And but on the CT scan, because it's a pre-operative CT scan, the anterior wall is still there. Yeah? Okay. This is an example of how it works in the OR. Here, the frontal sinus has already been opened. As I go in with a probe, you can see that it's moving up to show me where the frontal sinus is. Right. Okay. Right. It is going into the frontal sinus. The probe has gone into the frontal sinus. Okay. As I take it out, on the medial side, lateral side. Okay. Okay, sorry, this is a space shuttle problem. So the image guided system is particularly useful for revision cases where anatomical landmarks are no longer exist. It's useful to have for fresh FESS cases, but it's not necessity. Because I have a research grant to use the image guided system, I use it for every case now. So we have done our 70 cases with the image guided system, just to test it. Yeah. There are economic considerations. Basic systems cost 150,000 US. ENT upgrade in the US may cost up to 50,000. In Singapore, we obtained it through a grant for about 300 US thousand dollars. So it is not possible to recover these sort of costs from patients. There are higher operative costs. We need technical personnel. We have a nurse specifically to run the machine for us, with us. There are disposable items in the system that I use. The insert track, where we have to have a disposable headset, disposable aspirators, and they all cost money. Yeah. The CT scans also cost more because the radiologist tells me that we have to use 1mm cuts. He uses more of their CT scan tube, and so they charge more for the CT scan. And we have not have coding for image guided system, not in the US, not in Singapore, so there's no extra charge now for the image guided system, and therefore difficult to recoup the costs. When you have an image guided system, then the world is divided into a few types of people. One who never use it, like the small bear, ones who use it sparingly, and those who use it only for complex cases, and people who use it all the time. Yeah? The question is, will it come a time when image guided systems become so cheap that just as for a CT scan that you require for FESS, you might require image guided system for all the cases? Yeah? We'll have to wait and see. Yeah, hopefully not. But sometimes in a medical legal problem where in a complex case, if it's available and it's not used and there's a complication, it might be a difficult position for us to face the people like in the Supreme Court House in Singapore. Of course, a word of caution is that when you have an image guided system, it doesn't mean that it's a substitute for surgical knowledge and expertise. It mustn't give us false sense of security. It's very important you attend good FESS courses, learn from good FESS teachers like this character here, and of course continue to observe and to learn FESS the normal way. Yeah? Image guided system is just an adjunct. It helps. Yeah? Okay.